Welcome to Harlow on Healthcare. I'm David Harlow, and I invite you to join me by my virtual hearth as I sit down with healthcare leaders to discuss building the future of healthcare. We are live at HIMSS 2019 with Jim Grana, PhD, Chief Analytics Officer at Rush Health. Jim has worked previously in senior roles at payer organizations as well. Welcome, Jim, and thanks for joining us.
It's great to be here.
So every healthcare organization is continually wrestling with the quadruple aim: improving patient experience, improving population health, reducing costs, improving provider experience. And I wonder if you could give us some insight into how your role as Chief Analytics Officer at Rush Health has brought you in touch with these issues and what you're working on these days.
Well, we struggle with these issues all the time to try to improve quality, improve the experience for both providers and patients, and reduce costs overall. We use a lot of data right now to try to reach these aims, and we're doing relatively well in terms of at least progress along that continuum. A lot of the struggle for us has to do with integrating data from across the network. And when I say across the network, Rush Health is a clinically integrated network with 4 hospitals, actually 3 medical centers and 1 hospital, and 1,500 providers, and they're not all on the same platform. So the first step in the process for us is integrating data. We have an HIE effort underway that's enabling us to do that. Followed by the second activity, which is analytics, straight analytics, to try to get some meaning out of the data, provide meaningful lists to providers and outreach to the right patients. And then third, it's kind of an activation workflow dimension associated with what we're trying to accomplish. And that is, it's one thing to have the lists and to have the names and to have the insights, but it's another thing to actually put it into action.
Sure. So could you give an example of that activation layer and how we're putting it into action?
Absolutely. We have a number of activation layers, and it's a work in progress. But that having been said, one dimension of this would be in the form of getting information out via Epic, although not all of our providers are on Epic. So that creates a wrinkle for the non-Epic providers. There are a number of EHRs out there. We don't have all employed physicians. We have a number of independent physicians, independent offices. So in those cases, we provide the providers themselves with lists of patients to take action on. Then it's those physicians charged to get those lists into their own workflow as it stands right now.
Okay, so it's a collaborative effort then.
Yes.
Across the network, so to speak. So I understand that part of what you're doing with this layer is looking at risk adjustment, which of course the first step there is really data capture. And I'm wondering if you could speak to how that is working and how that integrates with other aspects of the data work at that integration level across the various providers.
That makes sense. First of all, with the advent of all these shared risk and shared savings arrangements, measuring burden of illness has become central to the entire process in terms of how we get paid. Almost all the payers have a deep respect for the importance of understanding the burden of illness associated with those individuals that are attributed to us versus those that are attributed to our colleagues in other health systems in the greater Chicago area. That having been said, in order for those payers to understand what the burden of illness is that we have relative to others, we have to code better. They have to depend on codes, ICD-10 codes that usually roll up into some other system like HCCs or RAF scores, risk adjustment factors, to better identify the burden of illness that we have. This is kind of a new learning for providers. Historically, providers really didn't care as much about coding the diagnoses. They cared more about coding the procedures because they're not compensated typically on the diagnoses. So there's an educational process that goes into place. There's a process of identifying missing codes for chronic conditions that existed in the previous year, looking to see if they got recoded in the current year. If they weren't recoded in the current year, there are two things that we're very interested in. One was that patient followed up on properly from a quality of care perspective because they have a chronic condition. And two, we're very concerned because we want to make sure that those payers understand the true burden of illness associated with the patients that we treat.
Sure. Now, it's a common trope for large institutions to say to payers and others, well, our patient population is different, they're sicker, they come to us because they're more complex cases. Is when you peel back the layers of the onion, are you finding that that is proven out, or do you find there's a range of learnings from the data that you have accessible to you now?
Well, I think sometimes it's true and sometimes it's not true, although everyone says, of course, that their patients are sicker. So even the simplest or the most low acuity providing individual or physician or practice will claim that their patients are sicker than the data suggests. That having been said, however, when you look at an academic medical center, you do find that the practitioners are so focused on the care that they shy away from the administrative dimension associated with claim submission and coding. So with that shying away, there's a bigger gap. So you
just lose the data entry.
You lose the data entry right from the beginning without proper education and explaining to them why this matters, why this is important. Once you get the providers on board in terms of why it's important, the gap starts to narrow, and the narrowing is significant. I will say from the payer side, which most of my career, as you know, has been on the payer side. On the payer side, we always wanted to get as accurate of information as we could, even before we were reimbursing based on burden of illness, just so that we could risk stratify, our predictive models are more accurate with better data, our artificial intelligence engines are more accurate with more data, more accurate data, more consistent data. We've been pushing this for many years, but now that reimbursement is based on burden of illness, it's becoming more central to providers as well.
Well, sure. Now you have the attention of the provider.
Absolutely.
Right?
It worked. It works, yes.
Right. So this is part of a broader trend, obviously, of value-based care, and this has been this is a continual theme that we're talking about, and we've been talking about it for going on decades now, and now it feels like we're actually doing something about it. Do you see that as well? Do you feel like this is some sort of watershed moment at this point because of the way that providers are now in this game as well?
I do. For the first time, you could just really feel the pressure associated with value-based care contracts. 3 years ago, maybe even a shorter period of time ago, providers were resisting value-based care, resisting shared savings and shared risk arrangements. Now, it's hard to deny that value-based care reimbursement schemes are here to stay. CMS has made it crystal clear they're pushing value-based care. The commercials are jumping right on board, and they're pushing their different models as well. There's not a major commercial carrier that I'm aware of that isn't pushing some form of value-based care, which requires proper coding. The pressure right now is just palpable.
And some of those commercial payers preceded the Medicare push in this area as well. So they're now all sort of moving in the same direction, I guess.
Good point. I could remember I'll go back to U.S. healthcare in the 90s when we had our large HMO when managed care was in favor. Data was king then as well from a claims perspective. Then, as we know, it waned for a while when managed care went out of favor, and once that occurred, the interest in diagnosis codes seemed to kind of wane a bit as well. But you're right. Over the last several years, the commercials have been pushing this.
So I understand you're working to improve care with the revenue that you're able to bring in thanks to these changes and in reimbursement as a result of these coding changes in the risk adjustment arena. And so what does that mean in practical terms for your organization? Do you see a direct correlation to benefits for patients, for providers? Are there other certain populations being served differently, better? How does this tie in with the quadruple aim?
Absolutely. The data that we have now, and the better the data, the better the models, the data enables us to reach out to the right patient with the right intervention. It's kind of targeting individuals in a manner that's more consistent with their needs as opposed to targeting the wrong group of people. Better data, better predictive models, better artificial intelligence. When you have the better predictive models and artificial intelligence, you target the right patients such that they're not bothered by spurious outreaches and programs that don't really apply to them. So that targeting is very good from the patient perspective. From the provider perspective, it makes us more efficient. We can't afford to reach out to every diabetic or every asthmatic or to every patient that we ever see. But we can afford to reach out to those who are at high risk of some type of acute exacerbation. If we reach out to those individuals that are at higher risk for the acute exacerbation, say it's 1%, 5% of the population that I'm referring to, say 5% of diabetics or 5% of asthmatics or oncology patients, whatever, then we can start to execute programs that we wouldn't otherwise be able to afford because we can't reach out to everybody. The ROIs go up, the return on investment goes up when we reach out to the right patients. It's good for the patient, it's good for the provider, it's good for the healthcare system. It's more satisfying to all involved to have really sound and tight predictive models that are helped by having good data.
If you're just tuning in, this is Harlow on Healthcare, coming to you on HealthcareNOW Radio. I'm David Harlow, and my guest today is Jim Grana at Rush Health. So we've been talking a little bit about risk adjustment being not only a Medicare issue, but also a commercial payer issue. I'm wondering, have you incorporated these learnings in risk contracts with commercial payers as well as government payers? What does your payer mix look like? How does this play out differently in different populations?
It works pretty consistently across payers because when we have an ACO arrangement or shared risk or shared savings arrangement with a commercial or a governmental plan, we get typically full data in and out of network. When I say full data, I'm referring to full claims data in and out of network. So in those cases, we do the same types of things, the same types of modeling, outreach, provider performance measurement, outcome studies, because the data is relatively consistent. What I would like to see is perfectly consistent data such that we can get allowed amounts, paid amounts, all those kinds of things from the commercials, as well as what we do get today from the government programs.
I'll hold while you get that perfect data.
Oh, yeah. Well, that might be a while, and I realize that. But standardizing the data it would be very helpful for us because we can't have an intervention that just applies to this 25,000 this group of 25,000 patients, and then another set of metrics and interventions for this 25,000 patients. We have to summarize all the data for all of our patients and have one streamlined set of messages to our providers. Otherwise, the providers become confused and frustrated with having too many messages. We can't have one message for Cigna and then one message for Aetna and one for Blue Cross Blue Shield and something else for MSSP and so on. So we really do need to standardize the data, standardize the message, and make it more straightforward for patients and providers alike.
Well, as you mentioned, MSSP just calls to mind the fact that over time we've moved away from upside-only risk sharing from Medicare to two-way risk sharing, and I'm wondering what is the appetite in your organization and as you see it in other organizations around the country for that downside risk sharing? Are the analytics now able to support that real taking of risk as opposed to building up in hopes of obtaining an upside payment?
Well, first of all, currently, Rush Health is in an MSSP Track 1 program, so we're still upside only. That having been said, we are concerned about the volatility associated with relatively small sample size. Again, most of my background is from the payer side. So with that background, I have a complete appreciation for the volatility that we're likely to see when we go downside risk that might kind of be a red flag about the risk that we'd be bearing if we took on too many downside risk arrangements without proper protections in place.
Sure, and we need proper protections in place for you when your CFO comes knocking.
Absolutely,
right?
Absolutely, and I'm risk averse, as you could imagine. Most analytical people are, and I think that's a very good point. I need protection from that CFO.
Right. So, what would you say are some of the hardest parts of rolling this out, as far as you have already done so?
Well, when you say rolling this out, you mean code capture or the shared risk arrangements?
I mean the code capture in support of the shared risk.
I think it's education. I think it's still a journey that we're on. In the presentation that I gave yesterday here at HIMSS, the feedback that I received from many of the people after the presentation was they're at the early stages of trying to convince their providers of the criticality of code capture as well. And a number of these providers are very busy people. They're so busy they don't want to spend time, an extra hour a day or whatever it is, engaging in additional code capture and documentation and clicking more boxes in their EHRs.
I'm shocked.
Yeah, I know this is a common theme. There is administrative fatigue at this point, and so it's really convincing them that it's worth their time. There are other solutions, and I think we need to explore those other solutions more thoroughly. Some of our practices have connected with scribes that assist them with this process. I'm a proponent of mid-levels and scribes assisting with some of these activities such that we can be more efficient for the provider who is so fatigued.
Are these payment models yet getting to the point where we can get away from the 12-minute office visit so that even having the scribe in the room, freeing up the provider from doing the data entry job, do we have a more enhanced connection to the patient as a result?
I haven't done an analysis on this topic, but logic would tell me that makes sense, that the more time someone else is taking care of administrative duties, the more time the provider can have to connect with the patient. So logically, that makes perfect sense.
So if you were starting this journey from scratch, are there things you would do differently?
Oh boy, that's a good question. Certainly, if I were starting the journey for the health system from scratch, I would standardize the data more completely and more thoroughly early on, such that in-network, out-of-network, the different EHRs would connect more seamlessly. That would make our job much easier from a clinically integrated network perspective. Measuring provider performance and identifying patients that are at higher risk for acute exacerbations would be easier if the data were already standardized, but that's part of our job at Rush Health, and we've invested very wisely in doing that type of thing. But I think that would be the first thing that I would do. The analytical engines, there are so many. We have our own platform and our ability to build a number of our own analytical outputs and models. That is something that I would just double down on in terms of investment. And then the front end, if I could start it over, I would make it very seamless. And there are a number of different mechanisms to make it seamless, but I'd try to make it as seamless as possible for the provider and the patient.
So you've spoken a bit here and there in our conversation about analytics, about artificial intelligence, and I'm wondering if you could highlight a couple of things that you're doing in that realm, using the data in ways that you haven't been able to do before, thanks to the advances in artificial intelligence.
Sure. We have a number of mechanisms that are designed to identify those who are most likely, as a concrete example, those who are more likely to be admitted or readmitted for congestive heart failure, or those who are most likely to end up in the ER or become frequent flyers in in an emergency room, in or out of network. Those models, when triggered, provide real-time feedback to our medical management staff and to the individual providers, the individual patient's attributed provider. So that turns out to be very, very helpful in terms of using the data, using the intelligence that we can derive from identifying patterns in the data that would trigger some type of activity among our providers.
So the ED example is, of course, one that would end up, being of financial benefit as well as clinical benefit. The cardiac care example is one area where there's a ton of data in cardiology. There's a ton of data in orthopedics. Those are sort of, in some respects, the low-hanging fruit. Do you see any particular areas or certain chronic care issues, chronic disease, such as diabetes? Are there other areas where you see something on the horizon that you'll be able to collect, use, build tools using data in other areas, clinical areas that go beyond these sorts of specialties? I mean, there's a certain set of things that we hear a lot about, and sort of what's next. What do you think is next, or what do you hope is next?
Well, first of all, there are so many opportunities. There's an endless list of opportunities when it comes to interventions, outreach. So to be honest, when we create our own models with our own data, we end up coming up with a better model than when we purchase an AI model or predictive model from a third party, mainly because our own data has its own idiosyncrasies. Every organization's data has its own idiosyncrasies. So what we try to do is leverage our own data, create our own models with our own data, and reach out to those who would benefit the most from certain interventions. Now, the areas where we're focusing in right now center on things that are chronic and costly: place of service, admissions, readmissions, ER utilization, post-acute care. Those are some of the central areas that we're focusing in on at the moment. And the list grows. We've got a long list, but those are the things that come to the top at the moment. Certainly diabetes, COPD, congestive heart failure. These are the areas where we want to catch codes better, but we also want to outreach more efficiently.
Great. And you mentioned that the idiosyncrasies of your own patient population inform the development of certain models, and that makes a lot of sense. I mean, there's a concern generally where we look at what is the population that the model is built on, and is it going to be useful for my population? So you've addressed that directly. More broadly, there's obviously a concern in developing models for broad use and underrepresentation of different populations in the data sets that are used to build those models. So it's interesting to hear you say that you're looking at the homegrown model as most appropriate for your home population.
Yeah, actually, you're raising a good point and bringing up another thought. One, if we have enough volume, we want to use our own data for the more common diseases. For diseases that are rare, where we don't have enough volume to create our own model, we have to depend on a third-party model. But we don't want to be creating models based on the limited data that we might have for an obscure rare disease. But on the other hand, our own patient population is unique, and our own data sets have their own idiosyncrasies, as all data sets do. So we really do want to leverage our own data to the extent possible for those scenarios where we have an adequate sample size.
Great. So I'd like to close with asking you sort of a beyond the horizon kind of question. And if you were to wake up tomorrow and find yourself 5 years in the future, what is one thing in healthcare that you would hope or expect has changed drastically?
I think one of the biggest changes would be standardized data. If 5 years from now we could have standardized available data on a consistent platform, enabling us to really measure the population in a consistent fashion across payers and across providers, in network and out of network, that would be remarkably beneficial for the American health system.
Well, tune in 5 years, and we'll see how we're doing. Thank you very much for joining me today.
It's a pleasure.
You have been listening to Harlow on Healthcare. Join us at HealthcareNOWradio.com. Let's continue the conversation on building the future of healthcare together at #HarlowOnHC. I'm David Harlow, coming to you live from HIMSS, keeping the fire going and holding a seat open for you. Until next time.